to record or would like to ask a question, please indicate so in the chat. We will limit questions to one question per outlet, and we are limited to 1 hour today. If your question is still remaining in the queue when we conclude at 11:30 and you feel it hasn't already been answered, please feel free to send your question in the chat or by email, and we will work to get you a response in writing. All right, good morning. It is now 10:30 a.m., so we will go ahead and begin. I will turn it over to you, Dr. Vanderhoff.
Well, good morning. I'm Dr. Bruce Vanderhoff, Director of the Ohio Department of Health. Thank you for joining us today. As we've discussed in previous weeks, we continue to see very high numbers of COVID-19 cases and hospitalizations. Across the state, cases to date now exceed 1.4 million Ohioans. Sadly, we continue to see more Ohioans ending up in the hospital. And in the Ohio Hospital Association data, they're reporting that 1 in 6 hospitalized patients in Ohio is positive for COVID-19, and 1 in 4 in the ICU are battling COVID-19. Thankfully, we are seeing early indicators that cases appear to be peaking and beginning to point toward a decline. I'd expect that hospitalizations and deaths should soon follow. Now, I know it has been a very long journey. We're all tired of dealing with COVID-19, but I'd ask everyone to hang in there. Although our cases of COVID-19 remain extremely high, it is clear that our collective efforts really are paying off. We need to remain vigilant, and we need to protect ourselves from the spread of COVID-19 through vaccination, and especially in our schools where so many of our students either cannot or have not yet been vaccinated, wearing a mask. These are the keys to not only remaining healthy, but also to alleviating the currently intense pressure that is on our healthcare systems and our children and adult hospitals, really across the entire state. Today, I'd like to share some information about a few new dashboard changes that you may notice moving forward at our coronavirus.ohio.gov site. First, consistent with CDC reporting, we will be listing additional doses on our COVID-19 vaccination dashboard. Starting this afternoon, there will be a new drop-down menu that will show how many Ohioans have received additional doses. Secondly, we often receive questions about vaccination among specific age groups that are not currently listed on our dashboard, particularly for school-aged Ohioans ages 12 to 17. This information also will now be available as a new dashboard under the Vaccine tab. And it will share information for supplemental key age groupings, both at the county and the state level, including age brackets of 12 to 17, 18 to 19, 30 to 59, 60 to 79, and 80 and up. Finally, as a part of regular public health practice, the Council for State and Territorial Epidemiologists and the CDC collaborate every year to create an update for case definitions for public health surveillance. Case definitions are important because they provide a national standard framework for how to count and classify any disease, including COVID-19. As a part of the most recent review process, the case definition for COVID-19 was updated to reflect our latest understanding of the virus and how it works, and it has broadened that definition to include those who might be reinfected with COVID-19 90 days or more after a previous infection. So, in alignment with national guidance, the Ohio Department of Health will be counting any individuals reinfected with COVID-19 from September 1st on as a new case. And that will be reflected on our dashboards based on the specific, confirmed, and probable case definitions. So that part won't change. Although the state and local health departments have been implementing proper public health action for reinfected individuals all along, such as isolation of infected individuals and quarantine of their close contacts, these new infections haven't been counted on the dashboard because they didn't meet the case definition standard. This updated definition provides better insight into the real spread of COVID-19 across our communities. The new definition does not apply retroactively to any individuals who might have been reinfected prior to September 1st. For example, someone who may have been infected in April of 2020 and again in January of 2021 will continue to only be counted one time, as this was the case definition at the time. If that person's infected today, their new case will be counted in addition to their original case. So for clarity, only new reinfections after September 1st will be reflected on the dashboard, and they won't be separated from other cases. Much like anyone else infected, they'll simply count as a case. It's important to note that emerging information shows that those who are not vaccinated are in fact more than twice as likely to be reinfected compared with those who are fully vaccinated. All the more reason to choose to be vaccinated. I'd also like to provide a brief update on the distribution of monoclonal antibodies here in Ohio. I want to start with the fact that these therapies have become an important tool in Ohio for treating those who have had a positive COVID-19 test and have been symptomatic for 10 days or less. They also need to be at high risk of COVID-19's more serious symptoms. In recent months, utilization of monoclonal antibodies has increased significantly in Ohio, with thousands of doses weekly now being administered at our hospitals, long-term care settings, community health centers, dedicated infusion centers, and other locations able to provide this intravenous-based therapy. Some of you may be aware that a couple of weeks ago, the federal government changed the way in which these important therapeutics are distributed. Instead of allowing providers to order directly from the wholesaler, which had been the practice until recently, allocations were shifted to the states, and states were put in charge of assisting with an equitable distribution among individual providers across the state. Keep in mind, however, that the supplies themselves continue to be maintained and distributed by the wholesaler, in our case, AmerisourceBergen, and are never possessed by the state. We are simply helping to facilitate the allocations and orders. This fairly sudden change by the federal government caused a significant disruption to the states and providers, largely because it was unexpected. So hospitals, pharmacies, and long-term care settings, and other providers weren't aware of the change until they found themselves not receiving orders they were expecting. We immediately engaged the Ohio Hospital Association, the Ohio Department of Aging, and many other stakeholders to get the monoclonal antibodies where they needed to be and to develop a thoughtful process for continued distribution. Fortunately, because we were already working closely with our stakeholders and because we had a process for state allocation earlier in the pandemic that worked quite well, we've been able to quickly get our arms here in Ohio around the process. We have some great provider partners, both large and small, who are working together to ensure that the process can work for all providers and we can get these life-saving treatments, these important therapies in the hands of providers who are able to serve their patients. The goal of Ohio's state coordinated distribution system is to maintain equitable distribution, both geographically and in regard to time, ensuring that providers are given consistent, fairly distributed supply over the coming weeks, while the federal government works to procure additional supply. Finally, note that the federal allocations of the monoclonal antibodies are based on the state's percentage of the country's 7-day COVID hospitalization rate and the weighted 7-day COVID-19 case counts. This determines any state's percentage of the available amount of monoclonal antibodies for distribution in a given week. So far, Ohio's share has actually increased. So we've been able to continue to aggressively provide the treatments to providers for use across our state among high-risk patients. Now, last week, the CDC issued a health advisory urging COVID-19 vaccination among pregnant women. In the advisory, they shared that as of last Monday, there had been more than 125,000 laboratory-confirmed COVID-19 cases among pregnant people, including more than 22,000 hospitalized cases and 161 deaths. They went on to share that the highest number of COVID-19 related deaths among pregnant patients in a single month of the pandemic was reported in August, with 22 deaths across the country. The advisory also said that nationally, approximately 97% of pregnant patients hospitalized, either for illness or for labor and delivery, with a confirmed case of COVID-19 infection, were in fact unvaccinated. As of mid-September, the CDC said that only about 31% of those who are pregnant were fully vaccinated before or during their pregnancy. Right now, the majority of pregnant women remain unprotected against COVID-19, putting them and their unborn babies at risk. Joining me first today is Dr. Kamala Dixon. She's assistant professor of obstetrics and gynecology at the Ohio State University Wexner Medical Center. Dr. Dixon, could you share with us what some of the risks are to a pregnant woman who may become ill with COVID-19?
Absolutely. So there are definite increased risks to pregnant people who get COVID. We have seen an increased risk of preterm delivery in patients who have COVID. And we know that preterm delivery is connected to increased NICU admissions and unfortunately infant mortality. Additionally, when you get COVID-19 during your pregnancy, you're at increased risk for severe disease. And what we mean by that is increased risk to being hospitalized for treatment. You have a twofold risk of being admitted to an intensive care unit. Additionally, increased risk for need for ventilation or ECMO machines. And as you've already shared, there is a 70% increased risk of death when you have COVID-19 and you're pregnant. And that number alone is just terrifying for those of us who take care of pregnant people in Ohio.
So it is fair to say that the risks to someone who's pregnant compared to an age-matched peer are much greater when it comes to getting sick with COVID-19.
Exactly. And I think it's tough because a lot of times, generally, I mean, my patients are young and healthy, and that's what happens when you get pregnant. But just because of the physiology of pregnancy, that puts you at an increased risk for severe disease with COVID-19. So you are now in the high risk category, whereas previously you may not have been that. Additionally, if you have other health issues like obesity or asthma or diabetes, you're at an increased risk for severe disease when you get COVID during your pregnancy.
Thank you very much. You know, we know that the CDC and the American College of Obstetrics and Gynecology have both recommended COVID-19 vaccines for those who are pregnant. Unfortunately, what we now also know is that the majority of pregnant women continue to be unprotected by these vaccines. How would you encourage pregnant women to make that important choice to get vaccinated?
I think that's tough. I get it. I have a 7-year-old son. I know what it's like to be pregnant and have to make that decision of what am I putting in my body? How am I affecting my baby? And I know that classically pregnant people were not included in many trials. But the benefit is that we do have the V-Safe program, which included about 161,000 pregnant people. And what we have information from that shows that there were no adverse effects. We also do have a separate registry that was developed by the CDC that had 5,100 pregnant people. And in a New England Journal of Medicine study that came out in the spring, they compared the people who got the vaccine and people who didn't, and those pregnancy outcomes were the same. So things like stillbirth, miscarriage, growth restriction, congenital anomalies, they were all the same. So we have pretty good evidence now that we say that this is a safe vaccine for you and your baby. The other thing that when I talk to my patients about this is the fact that when you get the vaccine, you start to produce antibodies, right? And when you make these antibodies, you can pass them on to your baby and give your baby protection as well before they're born. So people just need to get the vaccine.
Thank you so much, Dr. Dixon. Also joining me today is Dr. Lisa Egbert. She's president of the Ohio State Medical Association and vice speaker of the American Medical Association. Dr. Egbert has a solo practice in OBGYN in Dayton. Now, Dr. Egbert, children, and Dr. Dixon really pointed in this direction, children need the best start in life they can get. And that really begins with a mom's healthy pregnancy. Now, we know that pregnant women want what's best for their children. And I know from hearing from many of them that they're concerned about whether the COVID-19 vaccines really are the safest bet for them and for their babies. Now, we heard Dr. Dixon tell us, this really is beginning to be pretty clear that, this seems like the right choice. But when you have patients who express those concerns, how do you help them understand all of this?
Well, thanks for the question. First of all, it's so important to recognize what I call the mama bear instinct. Maternal instincts start even before we become pregnant, and it's very powerful. Every pregnant woman wants to protect her unborn child. So hesitancy is very understandable. That's why it's so important for us here and in my office to tell them what we know. We know, as Dr. Dixon pointed out, that we have seen no increased risk of vaccines in pregnancy. And the CDC, the American College of OBGYN, and the Society for Maternal Fetal Medicine all recognize that is true and have released statements to urgently increase vaccination rates for all pregnant women. So I have that posted everywhere in my office. I have those statements posted so everybody can read for themselves. And why? Because we know, as Dr. Dixon pointed out, that COVID during pregnancy is significant risk for both mom and baby. Pregnancy is an immunocompromised state. That means that you have a significant risk for severe COVID, 70% risk of death, as Dr. Dixon pointed out, and they're on the rise. As you noted, Dr. Vanderhoff, in August, we noted the highest rate of maternal deaths since COVID started. And that's all because of Delta. Delta is so much more infectious, and it's taken out our young, healthy, pregnant women. So I tell them, look, we don't want you or your husband to be in a position where you have to decide, is my life at risk? Is there risk for my baby? Imagine what it's like for that young dad when he has to risk delivering a preterm baby to save his wife. And even then, he still may lose either his wife or his baby, or even worse, both. And sadly, we've seen it right here in our ICUs in Ohio. So I tell my patients all of these things to help them understand that the risk of a vaccine, which we know is minimal in every study we've looked at, versus the risk of COVID in pregnancy is no comparison. And I ask them to please get vaccinated.
Thank you, Dr. Egbert. One of the other things that I hear a lot about is, all right, doctor, it's safe during pregnancy, but what about at the very beginning of pregnancy? Will getting the vaccine increase the likelihood that I might miscarry or have a stillbirth?
And as Dr. Dixon pointed out, every study that we have seen so far has shown no increased risk for the adverse effects or the adverse problems of pregnancy with the COVID vaccine. But there is an increased risk for stillbirth with COVID. We still see that teased out, that women who have COVID during pregnancy do have an increased risk for stillbirth. A lot of the prematurity risk is likely secondary to that need to deliver babies early to help moms save themselves from COVID. But no, the vaccine, we have not seen any significant increased risk. Over 161,000 pregnant vaccine recipients to date have been followed. And we know, again, that sadly only 31% of our pregnant patients are vaccinated.
What about moms who may be breastfeeding and worried about the safety of breastfeeding while vaccinated, or women who are really thinking about becoming pregnant? There have been a lot of concerns expressed out there about the question of COVID-19 vaccines and their impact on future fertility. Could you touch on both of those important issues, breastfeeding and fertility?
Absolutely. And I apologize. I am getting a message that my connectivity is waning. So I'm sorry. But I'll try to answer those two. First of all, breastfeeding. Even for women who have not been vaccinated during pregnancy, we have steadfastly encouraged them to be vaccinated for breastfeeding, because we do know that antibodies are passed through the breast milk to the infant. And as you know, children under 12 are not able to be vaccinated. So it is one of the few ways that our moms can help protect those babies. So absolutely during pregnancy, and if it isn't during pregnancy, as soon as you have delivered, please be vaccinated, because there is definitely an advantage for breastfeeding. And all of the studies so far have shown that there has been no adverse effect on fertility. Those are myths. They have been thoroughly debunked, and that is not something that I want anybody to walk away from. There is no risk to fertility for either male or female fertility. So again, if you're thinking about being pregnant, the best thing you can do for your future baby is to be vaccinated prior to pregnancy, or if you haven't been vaccinated yet and you are pregnant during pregnancy, and if you haven't been vaccinated during pregnancy, after pregnancy, so you can transmit those antibodies to your baby through your breast milk.
Thank you very much, Dr. Egbert. Well, COVID-19 vaccines continue to be the safest and most powerful tool that we have to get this pandemic under control. Those who are at higher risk for severe COVID-19, including, as we've heard, pregnant women, should talk to their doctor to get the facts about COVID-19 vaccines, as choosing to be vaccinated really can be the key to staying out of the hospital and to assuring that a new mom will be there for her infant. In addition to being vaccinated, we encourage people to wear a mask when advised and to practice proper preventive measures like washing your hands and staying home if you're sick. Finally, we are already seeing some flu activity here in Ohio. So remember that you can get both the flu and COVID-19 at the same time. So this is the right time to get your flu shot, but it's also the right time to get your COVID-19 vaccine. And remember, you can even get both shots at the same appointment. Now, before we move on to questions, I wanted to remind you that today, the Ohio Vaxxed School website launched at www.ohiovax2school, that's the number 2, ohiovax, the number 2, school, all one word, .com. This time, those ages 12 to 25 can enter to win one of the $2 million available scholarships totaling $2 million, including 150 $10,000 scholarships and 5 $100,000 scholarships. Now, we're hopeful that if authorization is granted to the Pfizer vaccine for those ages 5 to 11, we'll be able to expand this program to include those younger Ohioans. Again, all dependent on that authorization coming through. Those who are eligible can register themselves or their children today at www.ohiovax2school.com. And now, Alicia, I think we can take questions.
Thank you, Dr. Vanderhoff. Our first question is from Spencer Hickey with Hannah News.
Thank you. Regarding the Warren County Schools Testing and Quarantine Pilot Program, how long do you plan to gather data before making conclusions, and are there testing supplies necessary to expand it elsewhere?
Yeah, thank you. Those are two very good questions. What I can tell you is that program has only had about a week of activity. So it's really premature for us to be able to report on its impact and whether it's even proving to be practicable across the schools that are participating. But rest assured, we're aiming to make a decision about that sooner rather than later. We recognize that there's great interest in this kind of alternative to home quarantine, but we want to make sure that it is an alternative that is workable and an alternative that is effective. In terms of testing, you're right, this kind of program does increase demand on testing, but as we're looking comprehensively at testing, it's something that we're very mindful of. Rest assured, we would not expand this or roll it forward if we were not confident that we could support the testing that is needed for that. And actually, the workability of the current testing platform that we're trialing, the Binax Now tests, is also part of the question that we're looking at. So more to come. It's still very early, but rest assured, this is something that we understand is time sensitive and that there's a lot of interest in.
Thank you, Dr. Vanderhoff. Our next question comes from Chris Serenelli with WFMJ.
Doctor, thank you. And this question is not only for you, but all the other experts that we have who may be inclined to opine. It has to do with an article in the New York Times that essentially says COVID is in retreat. It kind of went into context about this noted 2-month cycle where we see infections surge, then they decline for 2 months. There was also a snippet from Dr. Gottlieb, from the former FDA commissioner, who said he is of the opinion that this infection, this latest wave, is the last major wave of the pandemic. So if you could opine and give us some perspective on both of those, please.
Yeah, first I'll take the second question and then move to the first. I read the piece. I thought it was very well stated. I think we're all hoping that indeed this is the last great wave. If it is, I think that will be because of the continued growth in the outstanding protection afforded by vaccination. I think in the article they quoted nationwide something in the 70s as the percentage of eligible Americans who had received vaccination. And here in Ohio, of course, the percentage of eligible people who are vaccinated is well over 60% and heading up. So those are encouraging signs. But again, they point to just how important vaccination is and the importance of the message that we're sharing here today about vaccination. So can't really make a good scientific prediction. I can express sharing the hope expressed by Dr. Gottlieb that indeed this is the last great wave. But as a doctor, I don't hang my hat too much on what I hope will be. I prefer to look at the evidence and the science, which tells me, you know what, if I'm vaccinated, I can sort of check that box and feel pretty confident that I'm going to be protected against the severe outcomes of this illness. Again, encouraging. In terms of where are we on the curve? Well, as I shared, if you look across the country, it is clear that Delta has begun to move into a declining phase very early on that declining curve, but clearly seems to have crested and be pointing down. Remember, Ohio was one of the geographies of the state that was on the sort of later end of that wave. And I'm confident looking at our numbers that we have in fact crested. And I've seen early indications that we too are heading towards that downward trend. But it's early, and I think that we ought to remain vigilant. Doctors, if there's anything that I missed or you'd like to add, please feel free to add.
I will just add that there are obviously other variants out there that we're hearing about. So while I would love for this to be the end, or say sayonara to all of this, I think we need to recognize that we are at 70% as a nation, and we maybe need to be closer to 90% to have real protection from whatever is coming next. We kind of felt this way in June, that maybe this was behind us. And as Dr. Vanderhoff said, I sure would like to see the numbers show us that before I get too excited about it being over. There are still pockets of the population that are under vaccinated. And as we pointed out, pregnant women in particular are only at 31%. So there are still people at risk of this really deadly disease.
I just want to echo what they've already said. And I think the other point is just to make sure that we don't lower our guard. We have to still stay vigilant against COVID and make sure that we're getting the vaccinations. I just fear that, the messaging that the numbers are decreasing and retreating will make people not as willing to get the vaccine, when really we know that's a protective factor.
Thank you, doctors. Our next question is from Caroline Cohen with ABC6 and Fox 28.
Hello. First and foremost, thank you all, doctors, for all you've done throughout the pandemic and for hopping on with us. We really appreciate you and your work. My question is kind of going off of Chris's in regards to the Delta variant and this downward trend. what are the holidays looking like? Last year, it was very stay home, don't do it. How, if we are vaccinated, if our families are vaccinated, can we safely do it? What do we expect? I mean, it's hard here because the weather might not be conducive to an outdoor Thanksgiving. So what can we kind of expect, and what should people be preparing for now that we are into October and about a month and a half away?
Well, thanks. That's a great question. And I think it is something we all need to be thinking about as we look ahead. So a couple of things that I think that we know. When it comes to wintertime respiratory viruses, COVID is certainly one of our considerations, but I think we also know it's not the only respiratory illness that can impact us that time of the year. There's also the flu, and there are other illnesses. So the first answer is get your vaccinations. Get your COVID vaccine, get your flu vaccine. The COVID vaccine is going to provide you with really remarkable protection against the severe outcomes of illness, particularly if your immune system is working well. Now, we also, though, have to remember that when we go indoors, respiratory viruses just spread more easily. There's not as much fresh air circulating. There's more opportunity for that respiratory virus to hang in the air and get to us. So we also have to use some good common sense. We have to remember that if we're going to be gathering together with a large group of all vaccinated people in the household, we can probably have a much higher level of confidence in that family gathering than if we're gathering with family members from all over who are largely unvaccinated. I think that still is going to pose a much higher risk circumstance, both for COVID-19 and the flu. So I think what COVID has taught us is, we've really got to remember what we were taught as the basics when we were children. We have to wash our hands. We have to be mindful of the spread of respiratory viruses. And, do we need a facial covering or to cover our cough with our elbow, et cetera. We are going to be dealing with COVID-19 as one of the respiratory illnesses that we contend with for a long time to come. Which for me is just one more reason to say, if I weren't vaccinated, I think I'd be going out tomorrow and get vaccinated. Doctors, what would you add?
Would add that you have to remember that there are children present at these parties who are not eligible for vaccine and who are probably going to school. And fortunately, they tend to be asymptomatic when they are infected with COVID. So you want to think about those vulnerable people in your parties and whether the children potentially could be bringing this disease to those vulnerable people. So again, I will say, if you're pregnant, you need to think about being vaccinated, and you don't want to go. I have an unvaccinated pregnant patient who was talking about going to a family wedding because it was really important to her to go to the family wedding, but she was really hesitant about getting the vaccine. We went through the whole process again about how important it is to be safe and that you are a vulnerable person. Elderly people, even those who are vaccinated, are getting breakthrough infections. So they need to be thinking about getting that booster before we talk about family get-togethers. So I just want to make sure that everybody is really thinking about what that big group of people looks like, because they're all ages. And we certainly don't want to put our most vulnerable at risk.
Thank you. I appreciate it.
Okay, our next question is from Lindsay Mills with WBNS 10 TV.
Good morning, and thank you for taking my question. This question is something that Dr. Egbert already sort of alluded to earlier, but I'd like to know why the message is so urgent for pregnant women to get vaccinated in terms of what you're seeing. Like, if you could describe why the message is so urgent.
Yeah, I'll let Drs. Egbert and Dixon, as practicing OBGYNs, address that one directly.
So I'll start, but I'm going to let Dr. Dixon finish up because I know she's seeing a lot more high risk at Ohio State than I am. Fortunately, I take care of relatively low risk pregnancies as just a general OBGYN, and I've been, knock on wood, very fortunate. But I certainly hear the stories of my colleagues who are facing pregnant women in the ICU in their late second, early third trimester, having to be delivered early because they are on a vent and are failing. I have a personal friend who is an OBGYN who had to deliver a 27-week baby and the mom died. It was a first baby, and dad here had, brand new dad, no mom, 27-week baby in the NICU. That's why. That's why in August we had the highest number of women die from COVID because while they were pregnant, and that just should not happen in this country, in this world, in this time.
Exactly what Dr. Egbert said. Just the levels of the pregnant patients we've seen in the ICU and the levels of death that we've seen. I mean, I think maybe I'm speaking out of turn for Dr. Egbert, but I think we both went into OBGYN because we like young, healthy, like it's a really exciting part of a person's life where they're bringing a baby in and just starting new families. And, I didn't go in for intensive care, and this is what we're seeing because of COVID. And, I think it's just the hardest thing in the office day in and day out, also because I'm not the type of doctor who lives in the doom and gloom. That's not how I counsel my patients. I like to make sure that they have all the information that they need and they can make the decisions that are best for them and their families. But it's important for me to mention the fact that if you get COVID, there's a 70% increased risk of you dying. And I don't want any of my patients to die. I don't want that. I don't want any women, any pregnant people in Ohio or in this country to die. So this is why we're getting so urgent about this message.
Thank you very much, Dr. Dixon. Our next question is from Adrienne Robbins with NBC4.
Hi, thank you guys so much for doing this. You mentioned Back to School begins today. Obviously, a lot of money going into this program, and this is on top of the millions of dollars that Ohio has already spent on vaccine incentives. What is the goal for this program that would make you feel like it was a success and that this is money that's being well spent?
Yeah, thank you for that. Well, what we've seen from the incentive programs, whether they are the state's incentive programs or incentive programs that have been offered by local health departments, is that they do seem to have a distinct ability to get people off the sidelines and into the vaccination line. Time really is of the essence here. We're heading into that winter respiratory season, even if, and I'm cautiously optimistic that it will be, that we're witnessing the beginning of the Delta wave decline. Even if that is true, we have to anticipate that there's still COVID-19 out and about, and that we're all going to need protection from that, including our school-aged population. And so what will make it a success from my point of view is that through this, we hear the voices of people in that age bracket saying, you know what, I was thinking about it. This really got me to think more quickly, more hard, and I went out and got that vaccine. Frankly, if you look at the amount of money that we're deploying, while it is a large amount of money, it is a tiny amount of money compared to having people hospitalized and in the ICU. And if we can protect, even a relatively modest number of additional young people with this vaccine, we will, in my opinion, have been very successful.
Thank you, Dr. Vanderhoff. Our next question comes from Joe Ingles with Ohio Public Radio and Television.
Thank you, doctors, for doing this. I wanted to ask, I've heard a lot of Ohioans who are carrying their vaccination cards now because, you know, certain things require proof of vaccination, and they're carrying them to different events and are afraid they're going to lose them. They would like to have a voluntary kind of passport system where they could store that like some other states have. Is there any talk of doing anything on a purely voluntary basis to help people keep track of their shots?
Well, thanks. That's a really good question. And let me talk a little bit about the vaccine cards and, more importantly, your vaccine record. Now, while we're not able to get you a replacement vaccine card if you lose it, there are a few ways that you can get access to your vaccine records. Because remember, that vaccination is a part of your medical history. It is an important part of the treatments or the care that you have received. So first, one option is to call the provider who administered your COVID-19 vaccine. They may be able to look up your records and provide you with some indication from their records of those vaccines and the dates that they were received. Secondly, if they're unable to help, you can call your local health department, who can attempt to look up your vaccine record as well, because there's a database that they can turn to. And finally, if that doesn't work, there is information on our website, coronavirus.ohio.gov, about how to mail a request to the Ohio Department of Health to request your vaccination records. Again, it's a very important but secure information because it is a part of your health record.
Thank you, Dr. Vanderhoff. Our next question is from Marielle Carbone with WCP.
There we go, unmuted. All right. Good morning. Dr. Vanderhoff, this is probably best directed for you. We have been, I'm sure you've heard about the Ivermectin case here in Butler County, and some of our hospitals not wanting to give that to a patient. The patient we've heard has passed away, who was not given the Ivermectin. So just wondering, has there been any medical change in opinion on the use of this? And for people that are going to see this man's death and say, hey, if he was given this, he probably would have lived, what would you say to them?
Well, you know, of course, we as doctors are on this press conference today because as healthcare providers, I think it goes without saying that any loss of life, any death from COVID-19 is something that we consider to be tragic. And we really want people to take every reasonable step to protect themselves. Again, you know, as a doctor, I look toward the science. I look toward what the medical literature is clearly telling me will work for my patients. And the data now is just overwhelming that your best protection against COVID-19 is to get vaccinated. If you are vaccinated, the likelihood that you'll end up hospitalized or in the ICU is vanishingly low. And then layer on to that, the further risk that even if you do end up in the hospital, that you'll go on to die is even lower. So it's the best treatment option that any of us can think of, actually a therapeutic preventative, but nevertheless, the best medical intervention that we can offer. So I want to say that at the outset. But, you know, secondly, when it comes to treatments, believe me, physicians across the state and across the nation are eager to provide our patients any treatment that we see a clear scientific indication is likely to provide substantial benefit, more benefit than harm. And the simple fact is that if one looks at the medical literature, there is not the kind of strong basis for believing that ivermectin is in that list of highly effective treatments. We clearly have other treatments available to us at our hospitals that are far more impactful and effective. And while I understand people hope for and are searching for other things, we have to wait until the data and the medical literature tells us, yes, that really is one of those other things. And right now, the data that I have seen would not lead me to that conclusion about ivermectin, which is a drug that, like many therapeutics, can have a host of very adverse effects on any patient.
Thank you, Dr. Vanderhoff. Our next question is from Jackie Borchert with Cincinnati Enquirer, USA Today Network, Ohio.
Thank you. And thank you all for being here. I want to go back, speaking of therapeutics, to what you were talking about earlier, Dr. Vanderhoff, with the monoclonal antibodies. That change in the federal government, I guess, allocating the therapeutics instead of the providers ordering them. Are we on the whole receiving fewer treatment doses than before? Are there fewer providers receiving them? Can you explain a little bit more about how that has changed our ability to get that treatment here?
Yes, thank you very much for that question. The impact of this fairly abrupt change on Ohio was more of sort of a brief, I'll call it transitional impact, because of such a sudden change. Providers really found themselves in the situation of not really knowing until they went to their usual source that they couldn't request what they needed through that pathway. So they were going directly to the company AmerisourceBergen, who's the distributor, as they had been doing for some time, and learned, no, there's another process. I can't really speak to the federal communication process. That's outside of my purview, but I can tell you this. Here in Ohio, we have just a fabulous, not only spirit of collaboration, but mechanisms of collaboration that allowed us at state to take that federal allocation, work with all of our partners to ensure that there was rapid and effective distribution. And actually what we've seen is a continued rise, both in our allocation and in our utilization. So if we, circled back to early in the summer, we were down to maybe a couple hundred monoclonal antibody doses distributed in any given week. And as we move forward to the recent weeks, we were in the thousands of doses that were being distributed in any given week. So I think that we've done very well in Ohio. I think it's because all along our providers have been very carefully following the guidance regarding treatment and eligibility for treatment. And I think it's also because we have a pretty robust capability in terms of the kinds of providers in Ohio who are capable of delivering intravenous therapy, whereas there are some other states in the nation that are simply not as blessed as we are with having so many and so widely distributed providers capable of doing outpatient infusion therapy. We remain encouraged by the uptake of monoclonal antibody therapy and grateful that our allocations have continued to rise.
Thank you, Dr. Vanderhoff. Our next question is from Dan DeRose with WOIO.
Good morning, Dr. Vanderhoff. Was wondering if we could talk about this idea of this maybe being the last big wave. Is that potentially because of a combination of, in Ohio, 60% vaccinated, nationwide 70% vaccinated, plus the sheer amount of people who have gotten COVID so far and now are producing natural antibodies? That basically, are we just running out of people for COVID to spread to?
Yeah, thanks for that question, Dan. I think that is at a high level has a lot to do with why more and more medical experts are pointing towards a credible hope that this may be the last great wave that we see. But I haven't heard anyone say that this is the last that we're going to see of COVID-19. Remember, this wave that we are currently in, if it has indeed crested, has crested at a level that was approaching the level that we were at before vaccinations in the middle of last winter. And that's despite the fact that when it hit us, about 50% of those who are eligible in the state, and it's gone up since, but at the time, about 50% were well protected by vaccines. So, I just can't imagine what this wave would have been like, how devastating it would have been if it had hit prior to a vaccine rollout. So what I think most people are looking towards in science and in medicine as we look ahead is that term that you've probably heard, this becoming an endemic illness. Now, endemic illnesses can still cause a lot of suffering and death, especially to people who are vulnerable. And what we saw during this wave is that the most vulnerable group, the group that this virus has been preferentially landing in the hospital and sadly killing, were the unvaccinated. So while I do believe, as do many medical scientists, that the immunity that we gain from infection, immunity that some call natural infection, it does provide a level of protection. I think it is something real. But as we look at this wave, I still have to pause when I consider, well, is my best bet natural infection or my best bet getting a vaccine? And what the facts on the ground tell me is, it was the vaccinated people who really didn't seem to be ending up in the hospital. It was the unvaccinated who were. So I think you'll see more study and more research in the coming weeks and months regarding natural immunity. But as a doctor, I can't help but look at the numbers and conclude that vaccination is the very safest way as this moves towards being an endemic illness to assuring that I don't end up tragically as a statistic, a vaccine preventable hospitalization or a vaccine preventable death.
Dr. Vanderhoff, our final question today is from Tom Jackson with the Sandusky.
Hi, Dr. Vanderhoff. Appreciate you taking my question. You said a couple times that you think we have crested with COVID-19 in Ohio, and I'm just wondering if you could point to what you are looking at specifically that makes you say that. Is it new cases? Is it hospitalizations? What are you referring to?
Yeah, so it's really a combination of factors, but the primary driver of my estimation is our cases per 100,000 and our reported positive daily cases. And when I look at our cases per 100,000 and do sort of the back of the envelope estimation of what I think we'll see as we get towards later in the week when we update that number, points to me towards that number for the first time in a long time probably being less than it was the week before. Not dramatically, but probably being less. And then secondly, when I look at the daily case reports, if not every day, then nearly every day for the last 7 or 8 days was less than its comparable day the week before. So Tuesday compared to Tuesday, Friday compared to Friday. That to me was a little ray of sunshine that said, maybe we've hit the top, because for the first time in a long time, I haven't seen those numbers be higher than their counterpart days in the previous week. So I feel fairly confident looking at those numbers that's the case. Now, if I look at hospitalizations across state, you can go onto our coronavirus website or the Ohio Hospital Association website. What you find is that our hospitalization numbers remain very high. But remember, those always trail behind by a little bit. And they've done that consistently throughout the pandemic. And of course, it's too early for us to say anything about our death numbers, because of the process of accurately recording cause of death takes a little bit of time as well. We've commented on that in the past. So that's the reason for my estimation really is those reported daily cases and the data coming in that feeds our cases per 100,000 calculations.
Thank you, Dr. Vanderhoff. That was our final question for the day. If you'd like to share any final closing remarks.
No, I just want to, again, thank our guests, Doctors Dixon and Egbert. Really appreciate, they have very busy clinical schedules, and your time away, I'm very grateful for. Also, thank those from the press who have afforded us this time to talk about these very, very important medical issues that are impacting our state. So thank you all.